Bismillahir Rahmanir Rahim. I'm Dr. Mohamed Ibrahim, Assistant Professor, Obstetrics and Gynecology, Mansoura University. I will present the topic of ectopic pregnancy for you today. For definition of ectopic pregnancy, it is defined as implantation of fertilized ovum outside normal uterine cavity. As you know, the usual site of implantation is inside the uterine cavity in the upper uterine segment, 60% in the posterior wall and 40% anteriorly. Incidence of ectopic pregnancy accounts for 2% of all pregnancies, but unfortunately this incidence increased due to increased incidence of chronic PID and sexually transmitted disease which is not properly managed, increased use of IUD, especially progesterone releasing IUD, increased rate of assisted reproductive techniques with implantation of or transfer of the embryo into the lower uterine segment or outside the uterine cavity, and better diagnostic tools for detection of ectopic pregnancy even before interruption. This photo shows different types of ectopic pregnancy, either tubal with different sites, ovarian, abdominal, interstitial, and the cervical one. For risk factors or predisposing factors, we have history of pelvic inflammatory disease or sexually transmitted disease, which will cause chronic salpingitis, history of tubal surgery, and contraceptive failure. Failure with use of intrauterine contraceptive device, especially the progesterone-releasing one, with subsequent reduction in the peristaltic movement of the tube and the delay of transfer of the fertilized ovum into the uterine cavity to be implanted. Failure with use of progesterone-only contraceptives, not conclusive cause. Pregnancy after tubal sterilization on the tubal stump. Use of fertility drugs for management of infertility and pregnancy by ART also increased the rate of ectopic pregnancy. Previous ectopic pregnancy with a recurrence rate about 10%. Increased maternal age. Highest rate occurs in women aged 35 to 44 years old. Smoking due to altered tubal motility, ciliary action, blastocyst implantation process. Others include previous DES exposure, which is an old cause. Now DES is not used. Previous abdominal surgery or ruptured appendix, uterine malformations, salpingitis, isthmic candidosa, and this means microscopic presence of tubal epithelium in the pyosalpinx or beneath the tubal mucosa. Regarding types and sites of ectopic pregnancy, most of cases are implanted in the tube, which is called the tubal pregnancy in 98%. Different sites, the ambulary, which is the commonest site, isthmic, fimbrial, and interstitial. While the non-tubal ectopic pregnancy, which accounts only for 2% of ectopic pregnancies, we have the abdominal pregnancy 1, ovarian pregnancy, and what's called intrauterine ectopic, where implantation occurs inside the uterus but not in the usual uterine cavity, like cervical pregnancy, angular pregnancy, pregnancy in the rudimentary horn, and intramural pregnancy. For complications of ectopic pregnancy, we have early and late complications. The early complication is related to the disruption of ectopic pregnancy with subsequent hemorrhage and shock, hemorrhagic shock or hypovolemic shock, DIC, RH isoimmunization in case of RH negative female with RH positive male, complications of surgery for managing ectopic, hemorrhage, infection, injury to the surrounding organs, anesthetic complications, and the maternal mortality. Ectopic pregnancy is still one of the leading causes of maternal death in the first trimester and accounts for about 11% of all pregnancy-related deaths. Late complications include secondary infertility and pelvic adhesions. We'll start to discuss the commonest type, which is tubal pregnancy. By definition, it's implantation of fertilized ovum into the tubal wall. Causes related to the tubal pregnancy include causes in the tube, tubal factors. They lead to delayed tubal transport with dissolution of the zona and implantation of the formed zygote into the tube. This could be mechanical, like congenital, long and tortuous tube, diverticulum or accessory ostium, traumatic microsurgery of tubal or after tubal sterilization, inflammatory, like pelvic inflammatory disease, which is the commonest cause of tubal pregnancy, which cause chronic salpingitis and leading to entrapment of ovum and interference with ovum transport. This is due to absence of ciliary movement of the tubes, which usually push the fetus towards the uterine cavity, and adhesions, narrowing, and development of strictures or diverticuli inside the tubal lumen. Second is the neoplastic, where tumors cause kinking of the tube, like in case of broad ligament swelling, fibroid for example, endometriosis with the associated adhesions and distortion of the course of the tube. We have a functional cause, like tubal spasm due to parasympathetic overactivity, abnormal ciliary movement, abnormal peristalsis, like in case of IUD, especially the progesterone-releasing one, or the use of progesterone contraceptives, which will affect the motility or peristalsis of the tubes, leading to delay of transfer of the formed zygote and will implant inside the tube. Sometimes the condition is in the ovum, like rapid dissolution of the zona pellucida and rapid implantation of the zygote inside the tube before it can transfer to the uterine cavity, or the migration theory, where there is transperitoneal migration, which is accepted theory, or transuterine migration, which is the rare one, where pregnancy occurs in one side and the fertilized zygote travel either through the peritoneal cavity or through the uterine cavity to be implanted on the other tube. Here we will find the corpus luteum in one side and the ectopic pregnancy on the contralateral side. Pathology. Uterine pathology, usually we have changes inside the uterus owing to the hormones of pregnancy. The size enlarged but not the size of 8 weeks. Consistency soft, it is a pregnant uterus. There is decidual reaction in the lining endometrium. We have what's called areocystellar reaction, where there is areas of hypersecretory endometrium characterized by nuclear pleomorphism, hyperchromatosis, and absence of chronic villi. For the tube, there is decidual reaction, but the reaction is patchy, incomplete, and deficient in function. There is no sufficient hormones, so trophoblasts erode into the tubal wall, and the implantation occurs deep in the muscle layer of the tube wall, and the ovum becomes surrounded by, from one side, thin layer of muscle and the peritoneum coverage to the exterior, and from the other side, thin muscle layer and the mucosa of the tube. After implantation, there is picture of what's called undisturbed ectopic pregnancy, which is one of the varieties of ectopic pregnancy. But pregnancy will not continue due to unfavorable environment. There is deficient decidual function, thin tubal wall which will rupture easy, and disruption will occur usually at 6 to 10 weeks gestation, giving the picture of disturbed ectopic pregnancy, which have one of the following pathological types or fates, depending on whether the disruption occurs towards the lumen of the tube or towards the outer surface to the peritoneal cavity. This photo shows what's called tubal abortion, where the disruption occurs towards the lumen and the product of conception is expelled from the ostia of the tube towards the peritoneal cavity with bleeding but without rupture of the wall of the tube. So if disruption occurs towards the lumen, this will lead to either tubal mole, where there is repeated attacks of a slight hemorrhage, the embryo will die but still attached to the tubal wall and become surrounded by clotted blood, forming a bloody mole. The fate is either shrinkage and absorption or forming hematosalpinx or pyosalpinx if infection superadded. The second fate is tubal abortion, most common in the ambulatory or febrile pregnancy. Pathogenesis occurs through separation of the embryo from the tubal wall, followed by its expulsion to the peritoneal cavity through the abdominal ostia. Regarding fate or types, complete, where bleeding stops and the products of conception are absorbed, which is the good fate, and incomplete, where bleeding continues due to incomplete separation or bleeding from implantation site. This will lead to either hematosalpinx, where blood clots in the tube when both tubal ends are closed, peritubal hematocele, where blood collects around the abdominal ostia, pelvic hematocele, blood clots and collects in the Douglas pouch, and diffuse intraperitoneal hemorrhage, which is the bad fate. If the disruption occurs towards the outer surface, towards the peritoneal surface, not the tubal lumen, we will have what's called tubal rupture. The incidence occurs in more than half of the cases and is more common in the Isthmic pregnancy owing to the narrow tubal lumen at that site. The fate is according to the site of rupture. Rupture in the roof or the size of the tube, which is related to the peritoneal cavity, and rupture, this will lead to pelvic hematocele and diffuse intraperitoneal hemorrhage. While if the rupture occurs in the floor of the tube between the two layers of the broad ligament, this will lead to accumulation of blood and forming broad ligament hematoma. Sometimes the rupture is incomplete or slow. This leads to what's called tubal erosion, where this very rarely occurs. Minute erosion occurs in the tubal wall and there is escape of the embryo surrounded by living chorionic tissue outside the tube. There will be a new attachment and the embryo will attach itself to the neighboring organs, omentum, peritoneum, giving the picture of secondary abdominal pregnancy. Local, we will find signs of early pregnancy present in all clinical types. We'll have tender cervical motion, which is called Dodds sign. There is pain on cervical mobility from side to side, and we will have tender adnexial swelling just in 50% of cases. The other type is the subacute disturbed ectopic pregnancy, mostly with tubal abortion. Symptoms include period of amenorrhea, short period of amenorrhea or no amenorrhea if pregnancy is disturbed before the time of the next menstruation, especially in the Isthmic pregnancy. Like we mentioned, narrow lumen will lead to earlier rupture. Pain, which is the commonest symptom, occurs in about 90% of cases, and it may be dull aching pain due to tubal distension, Kulki pain in tubal abortion, the tube is trying to expel its content, stabbing pain in case of tubal rupture, shoulder pain if blood accumulates under the diaphragm, vaginal bleeding, up to 70% of cases due to shedding of decidua after casting or decreasing the pregnancy hormones, and it usually follows pain. Notice that in case of ectopic pregnancy, the disturbed one, pain starts first, followed by vaginal bleeding, while in case of miscarriage, we will have bleeding followed by pain. Sometimes we have fainting attack. This is due to repeated attacks of hemorrhage and Kulki pain. And we have an important sign, especially in the chronic disturbed type, which is called bathroom sign, where there is urge to have bowel action followed by sudden syncope while straining at defecation. This is due to vasomotor disturbance following peritoneal irritation by the intraperitoneal hemorrhage. For signs, generally we will have pallor, tachycardia, and hypotension, signs of hypovolemic shock. Abdominally, we have lower abdominal tenderness and rigidity, plus or minus shifting dullness upon doing percussion of the abdomen. We have Collins sign, bluish discoloration around the umbilicus due to intraperitoneal hemorrhage. Locally, sometimes we will feel pulsation in the lateral fornix, Nixon sign, tenderness and fullness in the posterior fornix, Johnson's sign due to accumulation of blood in Douglas pouch, which is called pelvic hematocele. There is tender cervical motion from side to side and tender adnexia at the site of ectopic. For the acute disturbed ectopic pregnancy, mostly with tubal rupture, we will find symptoms related to short period of amenorrhea followed by acute lower abdominal pain and sudden collapse. Shoulder pain due to accumulation of blood under the diaphragm. Signs, there is signs of shock, the hypovolemic and the neurogenic shock, rapid weak pulse, low blood pressure, and subnormal temperature. Abdominally, we'll find marked lower abdominal tenderness, rigidity, and shifting dullness. Locally, doesn't give much information because there is marked vaginal tenderness, however, there is severe tender cervical motion. Chronic disturbed ectopic pregnancy with pelvic hematocele. There is history of recurrent lower abdominal pain and vaginal bleeding, usually post undiagnosed or unnoticed, followed by pelvic heaviness with symptoms of pelvic congestion, dysuria, dyschezia, rectal tenesmus, and there will be deep dyspareunia. With signs, we'll find only pallor due to loss of blood into the peritoneal cavity, but not the degree to cause hypovolemic shock. Abdominal, we will find pelvic abdominal swelling and Collins sign, bluish discoloration around the umbilicus. Locally, there is tender cystic swelling in the posterior fornix, pushing the uterus forwards and upwards, which is called pelvic hematocele. There is again tender cervical motion and tender adnexial swelling. For the last fate, which is advanced abdominal pregnancy, like we mentioned, if the pregnancy just erodes the wall and escape from such hole into the peritoneal cavity, attach itself to the neighboring structures, and this will lead to advanced secondary abdominal pregnancy. Regarding investigations for cases of ectopic, first we do laboratory tests. Urine pregnancy test may give false negative results if the disturbance occurred more than 2 weeks before. Serum B-HCG, single measure not useful except if we have negative test to exclude ectopic, or as if the discrimination zone or discriminatory level is already exceeded. We do usually serial measurement. In early healthy pregnancy, the beta subunit level normally doubles or at least increase by about more than 66% every 48 hours. There is doubling time. So if serum beta HCG level increased by less than 66% after 48 hours, abnormal pregnancy is diagnosed and ectopic pregnancy is suspected. Not usually ectopic, but there is abnormal pregnancy. Serum progesterone, which is not a common test, increase more than 25 nanogram per milli, no ectopic. Less than 5 nanogram per milli, there is ectopic pregnancy or non-viable intrauterine pregnancy. Notice that it will not discriminate between or differentiate between ectopic and falling intrauterine pregnancy. 5 to 25 nanogram per milli, this is inclusive. Other measures, which is not usually done, we usually depend on the beta HCG level and its doubling after 48 hours. Sometimes we can measure E2 level, inhibin A, PAPP-A levels. The second is ultrasound. Signs of ectopic pregnancy will have empty uterine cavity, visualization of true intrauterine gestational sac, mostly exclude ectopic pregnancy. However, heterotopic pregnancy is a very rare possibility. where we have a normal gestational sac inside the uterine cavity and another one in the tube. This is extremely rare condition, but we should exclude. Ultrasound showing empty uterine cavity, just thick decidua, but no gestational sac is noticed inside the uterine cavity. Sometimes we notice what's called pseudo gestational sac, where there is collection of fluid into the uterine cavity due to bleeding from decidualized endometrium in the uterus. To differentiate it from the true gestational sac, the true gestational sac is usually located eccentrically, not in the center of the uterine cavity, and usually beneath the endometrial surface. Presence of decidual cast, which is a white ring around the gestational sac, is usually present in the true uterine pregnancy and not with the ectopic cases. There is a true gestational sac and containing fetus pool. Notice the uterine cavity is empty and the sac and the fetal pool outside the cavity in the adnexal region. This is ectopic pregnancy. Sometimes you will find what's called cystic adnexal mass. This is a sign, may not denote ectopic pregnancy. It may be corpus luteum associating intrauterine pregnancy or any ovarian or tubal cysts. Presence of fetal cardiac activity in the sure sign of ectopic pregnancy. So, by ultrasound, if you find a cystic adnexal mass with fetal pool and pulsation, this is ectopic. If just a mere cystic lesion, different differential diagnoses including corpus luteum and sometimes ovarian cyst or tubal cyst not related to the ectopic pregnancy. Sometimes we notice presence of free fluid in Douglas pouch or pelvic hematocele, which is hematoma accumulating in the Douglas pouch. Using combination of ultrasound and the serum beta-HCG level, which is called discrimination zone, defined as serum level of beta-HCG above which true gestational sac should be seen by ultrasound inside the uterus in all cases of normal pregnancy. It equals 6,000 to 6,050 milli international unit of HCG in case of examining by abdominal ultrasound, and in case of transvaginal ultrasound, 1,000 to 2,000 milli international unit will be sufficient to visualize the intrauterine pregnancy. So, by combining both beta-HCG level in the discrimination zone and the ultrasound assessment, if we have empty uterus with beta-HCG more than the discriminatory level mentioned before, we'll have ectopic pregnancy. An old method to delineate the presence of blood in the Douglas pouch was called docentesis, where we can do aspiration of contents of Douglas pouch by a needle inserted through the posterior fornix. Our aim to diagnose hemoperitoneum. Diagnostic criteria of hemoperitoneum include aspiration of more than half milli with non-clotted blood. An old method also using endometrial curettage. Indication done only after documentation of non-viable intrauterine pregnancy where serum progesterone less than 5 nanograms per milli. We used it to differentiate between non-viable intrauterine pregnancy and ectopic pregnancy. Presence of chorionic villi will exclude ectopic pregnancy. Non-viable intrauterine pregnancy villi can be detected by floating in saline or histopathological examination. If we don't have chorionic villi, so ectopic pregnancy is diagnosed. But again, this is an old method not used today. The gold standard for diagnosis of ectopic pregnancy is laparoscopy. It is done in doubtful diagnosis or hemodynamically unstable patient. So we should do laparoscopy to diagnose, and we can treat ectopic at the same time. Regarding values of laparoscopy, diagnostic, presence of ectopic pregnancy and its size and exact location. We can delineate the presence of hemoperitoneum, presence of other conditions as endometritis or ovarian cysts. which if present with early intrauterine ovarian cyst, which if present with early intrauterine pregnancy can mimic ectopic pregnancy. We can also do therapeutic maneuvers for the ectopic pregnancy using the laparoscope. Differential diagnosis of ectopic pregnancy. Bleeding in early pregnancy. We should differentiate ectopic from abortion and vesicular mole. Also, we should differentiate it from causes of acute abdomen or acute pelvic pain during pregnancy and the mass in Douglas pouch in case of hematocele. For treatment, we have abbreviation SAM, surgically administered medical treatment, or no surgically administered medical treatment, which is called conservative, or surgical or medical. So we have either surgically administered medical treatment, or no treatment, which is the conservative management, or just surgical management, or just medical management. First, we should stabilize the patient by first aid measures, treatment of shock if present, and preparation of cross-matched blood. And then we go to the management. Surgical treatment is the main line of treatment. This is a laparoscopy photo showing left ectopic tubal pregnancy with blood accumulating into the peritoneal cavity and coming from the ostia of the tube. Surgical management can be done by different approaches, either laparoscopy or laparotomy. Laparoscopy is recommended approach in hemodynamically stable patient, although this is changed now and we can even do laparoscopy for the unstable patient, but we should first do first aid measures, try to stabilize the patient, and then do laparoscopy. Laparotomy is indicated in the following conditions: if we have ectopic gestational sac more than 4 centimeters, cases of hemoperitoneum, extensive pelvic adhesions, obesity, non-expert surgeon in laparoscopy, and unavailable laparoscopy. Again, these indications are regressed and we can do laparoscopy for almost all cases, but we should stick to the rules if we don't have any laparoscopy instruments available or the surgeon is not expert. If we don't have these items, we should do laparoscopy. For surgical techniques, we have either conservative method where the tube is left in situ and we just drew an opening to evacuate the content of the tube, doing what's called salpingostomy, where the tube is opened and evacuate its contents, leaving the wound opened by and healed by granulation tissue, or doing salpingotomy, where we do opening of the tube, evacuation of its content, and then closure of the wound, or segmental resection and then doing end-to-end anastomosis, where we resect part of the containing ectopic pregnancy, followed by end-to-end reanastomosis of the tube. The non-conservative method, doing salpingectomy, where we do resection of the tube or part of it containing ectopic pregnancy, and this is a recommended line for treatment. Actually, the conservative methods usually leave non-healthy tube, and this will increase incidence of recurrent ectopic pregnancy. For the medical treatment, we have indications, which is selection criteria, which include ectopic gestational sac less than or equal 4 centimeters, HCG level less than 15,000 milli international unit, non-viable pregnancy, no detected fetal cardiac activity, and of course undisturbed pregnancy with hemodynamically stable patient and no signs of active bleeding or hemoperitoneum. If we fulfill this criteria, we can give medical treatment, but this should be under strict observation. Of course, patient must be reliable, compliant, and able to return to follow up. No contraindication to use the drug, no hypersensitivity or no allergy of the used drug, and we can use it in abdominal pregnancy and cervical pregnancy. Contraindication: if we don't have the fulfilled criteria, medical treatment is contraindicated. The used drugs are methotrexate. We can give intramuscular injection of a single dose, 50 milligrams per meter square, most popular regimen. We can give it either direct local injection into the ectopic pregnancy or intramuscularly. Under ultrasound guidance or laparoscopy, we can inject methotrexate directly into the ectopic pregnancy, which is called salpingiocentesis. Methotrexate is not without side effects. It will cause temporary rise of beta-HCG level during the first days of treatment. It will cause abdominal pain, vaginal bleeding or spotting, and other side effects of methotrexate discussed in the gestational trophoblastic disease. Other drugs that can be used, we can use actinomycin D instead of methotrexate, antiprogesterone, which is under trial, monoclonal antibodies against HCG and still under trial. We have also expectant treatment for cases of ectopic pregnancy. The principle of such expectant management or treatment that some cases show spontaneous resolution with death of trophoblasts with progressive decrease in HCG level and absorption of products of conception with no selection criteria for expectant management include ectopic gestational sac less than 4 centimeters, evidence of resolution guided by decrease in the HCG level, asymptomatic undisturbed pregnancy, hemodynamically stable patient with no signs of active bleeding or hemoperitoneum, and of course the patient should be reliable, compliant, able to return for follow-up, and accepting the potential risks of tubal rupture. Next, we'll discuss other types apart from tubal ectopic pregnancy. First, abdominal pregnancy, which is defined as implantation of fertilized ovum into the peritoneal cavity. Actually, we have two types. The primary one, where the pregnancy is first and only site of implantation is the peritoneal cavity, and the secondly, where implantation was originally inside the tube and the fertilized embryo or fertilized ovum escape from the tube and get implanted into the uterine cavity, which is more common than the primary one. Fate, we have fetal death and absorption. We have fetal death and infection, fetal death and calcification, which called lithopedion, and continuation of pregnancy. Fetus may continue to grow and acquire false sac from the surrounding structures, may reach full term. However, due to unsuitable environment, these fetuses are mostly affected by severe congenital malformations. To diagnose abdominal pregnancy, we have symptoms including repeated attacks of abdominal pain with vaginal spotting or during the pregnancy, painful fetal movement, we don't have uterine wall to limit the movement, small size and abnormal shape of the abdomen, spurious labor pains may develop if the fetus reaches term. For signs, abdominally, we have abnormal abdominal contour, generalized mild abdominal tenderness, easily felt fetal parts, abnormal fetal lie and attitude, no Braxton Hicks contractions that occurs inside the gravid uterus during the course of pregnancy, and of course, owing to the unfavorable environment, we have growth retardation and sometimes ending into fetal death. This is ultrasound denoting the advanced abdominal pregnancy. The uterus is noticed in the pelvis and the fetus is swimming in the peritoneal cavity without surrounded uterine wall. Locally, the uterus is slightly enlarged, soft, and felt separated from the fetal sac. Fetal parts can be felt through the fornices. If the cervix is dilated, finger introduced into the uterine cavity to confirm that the uterus is empty. Investigations. We can do X-ray, but this is an old method. Fetal skeleton cross maternal vertebral column. In the intrauterine pregnancy, usually fetal skeleton is always in front of the maternal vertebral column and does not cross it. We can do ultrasound, CT scan, or MRI, which is diagnostic. Oxytocin infusion test, absence of uterine contraction after oxytocin infusion because the uterus is considered as non-gravid. On operation, we should find what's called study force diagnostic criteria for abdominal ectopic pregnancy, for the primary abdominal ectopic pregnancy. Normal tubes, ovaries on both sides, excluding that the pregnancy starts in the tube or ovary and then get dislodged and attached to the abdominal organs. No evidence of retroplacental fistula. Pregnancy is related exclusively to the peritoneal surface. Treatment. We should immediately terminate pregnancy. Don't wait for fetal maturity. Doing laparotomy and not cesarean section because we don't open the uterine wall. Then extraction of the fetus and manage the placenta. We should remove the placenta if the placenta is attached to non-vital organ, but if the placenta is attached to vital organ like liver, spleen, or any other vital organs, just ligate and cut the cord near the placental beds and leave placenta for spontaneous autolysis. Next, ovarian pregnancy. Definition. There is implantation of fertilized ovum into ovarian cortex, diagnosed by what's called Spiegelberg's diagnostic criteria on operation. Spiegelberg criteria includes pregnancy occupies site of ovary cannot be separated from it. Pregnancy is surrounded by healthy ovarian tissue. Gestational sac is connected to uterus by ovarian ligament. Healthy tube on the affected side, no adhesions between the tube and the ovary, and the mesosalpinx on the affected side is free from hemorrhage or masses. If we find these criteria at time of operation, we diagnose ovarian ectopic pregnancy. For the treatment, oophorectomy or wedge resection of the affected part of the ovary will manage the condition. These ultrasound show empty uterus and the surrounding ovarian tissue around the gestational sac with the fetal ball inside, and this is ovarian ectopic pregnancy. Another type of ectopic pregnancy is the cervical pregnancy, which is defined as implantation of fertilized ovum into the cervical canal. Diagnosis by the following diagnostic criteria. Empty uterus. Pregnancy is located below the level of uterine vessels. The concept is intimately attached to the cervix. This is to exclude it from the cervical portion, where the cervix is not attached to the fetus and the fetus is originally implanted into the uterine cavity and become dislodged and retained into the cervical canal without attachment. Cervical glands are opposite to the placental attachment. There is painless vaginal bleeding in up to 90% of cases. Treatment. We usually do hysterectomy is the ideal line if the patient completed her family. Sometimes we do medical treatment using methotrexate in undisturbed cases if fertility is still desired. The next type is cornual pregnancy, where implantation of fertilized ovum into the uterine cornu into interstitial portion of the tube. This is called interstitial pregnancy, or directly over tubal orifice, which is called angular pregnancy. These are two types of cornual pregnancy. Diagnosis. there is severe lower abdominal pain, Biscassex sign, which is asymmetrically enlarged uterus, embryo grow in one cornu. Upon laparoscopy, the interstitial pregnancy is differentiated from angular pregnancy by its lateral relation to the round ligament, where interstitial pregnancy is lateral to the attached round ligament to the cornu of the uterus, while in the angular pregnancy it is medial to it. Treatment. Usually, hysterectomy is the ideal line of treatment, while sometimes if the fertility is desired, we do conservative surgery, removing the cornua, doing cornual resection, tubal reimplantation in the uterus. Pregnancy in rudimentary horn. It is diagnosed as tubal pregnancy, symptoms and signs, while disturbance usually occurs delayed than the usual in the 4th or 5th month due to thick wall of the horn, which is capable to withstand the pregnancy for longer duration. By local examination, it shows swelling, which is soft, cystic, mobile, and continuous with the uterus but distinct from it. At laparoscopy or laparotomy, it is differentiated from tubal pregnancy by its medial relation to round ligament, while tubal pregnancy is lateral to it. Treatment, we do horniectomy, which is removal of the affected horn. This is a photo for the pregnancy in a rudimentary horn. We do removal of such affected horn. Ultrasound showing intrauterine pregnancy and another pregnancy in the rudimentary horn. A rare condition which is called heterotopic pregnancy, where there is a simultaneous existence of intrauterine normal pregnancy and ectopic pregnancy. The incidence of such condition is somewhat rare, 1 in 30,000 of pregnancies, and the incidence increased due to increased rate of ovulation induction and ART. The diagnosis: condition must be suspected if we have symptoms and signs of ectopic and there is intrauterine gestational sac with high HCG level after abortion. Treatment: we do removal of ectopic pregnancy like any tubal pregnancy using laparotomy or laparoscopy according to the condition and the state of the patient. Thank you.